four of us are doing all subspecialties of cardiology, 24/7 services. I hope we are very happy with the way we have started and the way we are growing up by looking at the number of patients we served and their prognosis, good prognosis outcomes. So I will start our academic program. This is basics of ECG interpretation. When someone life is in your hands, introductory knowledge is not enough. So usually a diagnostic test should be according to our basic teaching in biostatistics. Diagnostic test should be easily available, easily accessible. It should be cheap, and it should have high specificity and sensitivity in diagnosing a particular disease. So I feel ECG satisfies all of them. The only thing is, until we know how to recognize the subtle emergencies, it is a very bad test. So it depends upon observers' capability to observe to diagnose the emergencies which are subtle, and 100% we can't master anything, but day by day with practice we can make our knowledge better. Of course not perfect any time. So because we are going to decide the patient's life, so introductory knowledge is not sufficient. We should update so this is the basic electrical activity of a myocardial cell, in fact any neurological cell, any cell which can be excitable. So law of conservation of energy neither can only be converted from one form to other. Electrical energy will be converted into mechanical energy, like our ceiling fan, where electrical energy from the plug box will convert into mechanical energy, which is converted through the wires. SA node, the pacemaker of the heart, is like plug box. The conduction system is like wires. Once that electrical energy is transferred to the fan, it transforms into mechanical energy. Like that, ultimately the myocardial activity which results in pumping of the blood to the circulatory system is because of this electrical system which is set in the body. So basic fundamental three ions, sodium, calcium and potassium in transmembrane gradient. This picture shows how electrical energy is generated. Though the fundamental behind generation of electrical activity is sodium, calcium, potassium, the surface ECG which we see is different from intramyocardial ECG. The reason is, when we keep electrodes, one inside the cell and other is on the surface of the cell, the waveform which is generated is different from the ECG. Both are electrical activities. Both are generated by sodium, potassium, calcium. So the difference is, in ECG, both the electrodes are outside the cell and the electrical activity is recorded with the time. But when we see that phase 0, phase 1, phase 2, phase 3, phase 4, the electrical activity is compared with the intracellular milieu with the extracellular milieu. So this is the different conduction wire system. SA node, it will transform to atrial muscle, then AV node, his bundle branch, Purkinje fibers and ventricular muscles. The conduction velocities are different. 0.05 in SA node and up to 4 millimeters per second in Purkinje fibers. That is the conduction speed. If we see the SA node electrical activity, atrial muscle electrical activity and ventricular muscle electrical activity is different. Putting together, when the electrical activity is plotted against time, both the electrodes extracellular will generate a ECG, what we see in the ECG graph. Every basic point we should understand, because basics are everything. If we want to understand any pathology, any abnormality, we should know what is absolutely normal. If we see that orange color, that is endocardially located myocardial cell electrical activity, which is different from epicardial. The P wave, QRS are positive waves in the ECG. T wave also positive, but T wave represent repolarization. Though depolarization and repolarization are exactly opposite, T wave is positive in ECG, which is expected to be a negative wave, isn't it? The reason is, though the depolarization starts in the endocardium to epicardium, repolarization starts from epicardium. The epicardial cells gets repolarized early. That's why the epicardial repolarization is in reverse direction. The reason for T wave being positive in surface ECG. So the point is, T wave is expected to be negative because it is a repolarization, but it is still positive because epicardial cells gets repolarized earlier than endocardial. It has an implication in the generation of J wave in early repolarization syndrome, which is altered there. That is the reason for J wave generation. That we will discuss in the later. So the point is, there is a difference in depolarization and repolarization. This is the surface ECG showing P wave, PR segment, QRS complex, a J point, junction of QRS complex to the ST segment, and T wave, which is positive, expected to be negative. So a ECG lead will have two poles, a positive pole and a negative pole. It captures the electrical potential spreading between the two poles. The electrodes that are positioned on the limbs and the precardium are the poles where axis formed between the two poles is called a lead. What we connect to the patient they are not leads, they are electrodes. So whenever there is a negative electrode senses depolarization wave towards it, it will form a negative wave. When there is and vice versa. So towards a negative electrode, if depolarization wave traveling towards it, it will generate a negative wave. If a depolarization wave travels towards the positive electrode, it is a positive wave. This fundamentally is important in understanding normal findings and abnormal findings in a given lead. This is how the depolarization will spread from SA node, then AV node, then His bundle. Then from His bundle, first septum gets depolarized from left to right. The thick blue marks denotes the septal repolarization, labeled as number 1 is the initial QRS complex wave. If any lead looks at the depolarization towards it, it will generate a positive wave. If any lead looks at the same event away from it, it will generate a negative wave. So the depolarization will spread from septum left to right, then towards the LV, that second gray line showing the towards the major myocardial muscle mass, second wave. Then it will, the depolarization will spread towards base. Phase 1, 2, 3 decides different waveforms in different leads. And the left bundle is divided into left anterior fascicular and left posterior fascicle. And that septal depolarization is because of third fascicle, which is known as median fascicle. Actually, left bundle will have 3 fascicles. Median fascicle, which is responsible for that thick blue line septal depolarization from left to right, and left anterior fascicle, left posterior fascicle, and right bundle. So let us focus on understanding the waveforms in different leads. These are the standard limb leads: lead 1, lead 2, lead 3. Lead 1, always depolarization wave will spread from negative terminal to the positive terminal. Lead 1, because formed between 2 electrodes, right arm and left arm, it will travel from right arm to the left arm. So if we observe the center picture, septal depolarization followed by thick black picture, predominant myocardial depolarization followed by base. If we see, septal depolarization is away from the lead 1. That is the reason for having a negative Q wave in lead 1. That blue line is negative. Predominant depolarization gray line is almost towards the lead 1. That is the reason for positive deflection in lead 1. And base depolarization is black. So every lead, if we observe lead 1, lead 2, lead 3, the waveforms are different because particular lead will sense different phases of depolarization in different ways. This is the augmented leads which are derived from standard limb leads. AVR, very important, AVR is equal to right arm lead because it is focusing from center to the right arm. What is that center point? For standard limb leads, there is a right arm and left arm. For augmented limb leads, there is only right arm. The center point is the average of the rest of the 2 leads that I will show in the later picture. So AVR is right arm lead. It is located towards the right arm. AVL minus 30 degrees is a left arm lead. And AVF is a foot lead. Left foot and right foot both are equal leads. Both are same. So it's a foot lead, lower limb lead. If we observe the 3 phases of the depolarization, septal depolarization, predominant ventricular depolarization, followed by basal depolarization, 3 different waveforms in 3 different leads because they sense in the different direction. So if we see, blue is septal depolarization, gray is predominant ventricular depolarization, black is basal depolarization. That is the reason for different waveforms in different leads. These are the horizontal, first 6 leads are frontal leads, the movement they sense in this frontal direction. And next V1 to V6 are horizontal leads, they sense depolarization horizontal direction. Initial septal depolarization is sensed as positive in right sided leads, V1 and V2. In V3 and V4, that is towards positive, and V5, V6 predominantly positive. So from V1 to V6, if we observe only septal depolarization, that blue form, V1 positive, V2 positive, V3 positive, V4, V5, V6 are negative because they are looking at the depolarization as away from those particular leads. So lead 1, AVL, V4, V5, V6 are lateral leads. Presence of Q wave in those lateral leads is normal because septal depolarization is sensed as negative in those leads because they are laterally oriented leads. Small r in V1 is normal or can vary it because it senses the septal depolarization towards it. So let us approach ECG from in these following headings. Whenever required, we shall strengthen our basics. So first is standardization. We should observe the first standardization because we should not, we should start with proper standardization, which is equal to normal standardization is horizontal is time, seconds, and vertical is amplitude. 1 millimeter is equal to 10 mm in vertical direction. In a horizontal way, one small box is equal to 40 milliseconds. So in to diagnose certain diseases, we will change the standardization. Sometimes it mistakenly taken as a different standardization. We should observe before we conclude the diagnosis. Half standardization is we will make 1 millivolt into 5 mm. Double standardization is 1 millivolt will make it 20 mm. So this is how standardization. So standard is 1 mm horizontal box is 40 milliseconds. If we make it 50, it becomes 20 milliseconds. If we make it 5, it becomes 100 milliseconds. And heart rate will become half. ECG intervals will be 2 times the normal intervals. So this is very important because if we won't observe the standardization, the technical error will result in different pathologies. Is there any application to change standardization? Yes. If we observe the first lead to rhythm strip, which looks a regular rhythm with some bit undulated complexes between the two RR complexes. To observe what is happening between the two, we made 50 mm per second. Intentionally we made it 50 mm per second. There we can make out P waves. It is an atrial flutter with 2:1 conduction. So standardization we can change it to observe subtle abnormalities like hidden P waves. So there is an application, diagnostic application to change the standardization. Whenever there are small complexes, low QRS voltages, we can change the standardization. So next, rhythm regularity. Ideal way is to take a paper and point out both the RR complexes and compare, because at high rates it looks regular, actually it is not. Subtle irregularity can be made out only through paper if we point out 2 QRS complexes and we can compare to diagnose irregularity. Actually this looks regular rhythm, but it's an abnormal rhythm, which is a atrial flutter with 3:1 AV conduction. Regularity has to be confirmed with paper pointing out 2 QRS complex and comparing the entire rhythms. This is the heart rate. There are 3 methods to calculate the heart rate. There are RR complexes. There are 9 RR complexes. If we take small boxes, 1500 by 27 will give the heart rate. If we take large boxes, 300 by number of large boxes between the 2 RR complexes will give the rate. And third one, which is very important, we should utilize for the irregular rhythms. Entire 10-second strip, number of R waves into 6 will give the correct exact rate. In case of atrial fibrillation with fast ventricular rate should be estimated with this third approach. This is useful in irregular rhythms. So next, what is normal P wave? It's very, very important to diagnose to locate normal P wave. A normal P wave is upright in lead 1 to AVF, inverted in AVR, and its axis is 0 to 75 degrees. That I will tell you how to find out the axis. And P wave is biphasic in V1 and V2. Can be biphasic in V1 and V2, but sometimes can be entirely positive in V1 and V2, and it's always positive in V3 to V6. So these are the rules. 1, 2, AVF, V3 to V6, P wave is positive. This is needed to diagnose arrhythmias and localizing the pathologies. Next is axis. There are 2 axes for heart. One is horizontal axis, other is frontal axis. Frontal axis, frontal leads are 6, 3 standard leads and 3 augmented leads. So we can estimate the frontal lead axis in frontal leads. Horizontal leads are 6, V1 to V6. So we will diagnose the horizontal axis in chest lead. So electrical axis, as I have told, right arm to left arm standard lead is lead 1. Right arm to foot, whether it be right foot or left foot, lead 2. Left arm to foot is lead 3. Axis of the lead 1 is 0 degrees. Axis of the lead 2 is 60 degrees. Axis of the lead 3 is 120 degrees. These are the augmented leads. As I have told you, the imaginary lead for augmented leads is center point, which is created by averaging the rest of the 2 leads. If we observe something like to create an earth, for AVR, which is a right arm lead, the center point is framed by neutralizing rest of the 2 left arm and left foot lead. For AVL, left arm lead, other 2 limbs are neutral. For AVF, foot is the main lead and rest of the 2 are neutral. This is very, very important for localizing lead reversals. This anatomy knowledge is required. Normal axis is 0 to 90 degrees. Some book says minus 30 to 90 degrees. And above that, 0 to 90 degrees is left axis. Initial 0 to minus 30 degrees is known as physiological left axis. Minus 30 to 90 is pathological left axis. 90 to 180 is right axis deviation, and extreme axis or indeterminate axis is 180 to 360 degrees. So if we observe with the changing axis, the morphology and QRS complex morphology is getting changed in the frontal leads. Frontal axis can only be estimated in frontal leads. With the different axis, the morphology of lead 1, 2, 3, everything is getting changed. So this is the picture which gives all possible axis deviations. As I have said, 0 to minus 30 degrees is physiological left axis. Minus 30 to minus 90 is pathological left axis. So what are the causes for left axis? LVH, left anterofascicular block, left bundle branch block, and inferior MI. So if we see lead 1 and AVF, lead 1 and AVF are leaving each other. The QRS complex of AVF and lead 1 both are leaving each other. They are opposite, L for L, left axis. And how to differentiate that physiological axis from pathological axis? Lead, if we go from below downwards, lead 1, lead 2, lead 1, lead 2, AVF all are positive, which is normal. Lead 1, lead 2 are positive, AVF is negative, which is the left axis, but still there is lead 2 is positive. In above picture, lead 1 is positive, 2 and AVF both are negative, which is a pathological left axis. If lead 1 and AVF are leaving each other, left axis, then we should focus on lead 2. If lead 2 also negative, that is pathological left axis. All left axis are not pathological. Minus 30 degrees can be physiological. Once pathological, lead 1 is positive, lead 2 and AVF are negative, only 4 DDs, left ventricular hypertrophy, left anterofascicular block, left bundle branch block, and inferior MI. We shall see how to differentiate both. If we come to the right axis, lead 1 and AVF are reaching each other. If we see the lower picture, lead 1 is negative, which is towards AVF. AVF is positive, both are reaching each other, R for R, right axis. So these are the differential diagnosis for right axis, right ventricular hypertrophy, if it is acute pulmonary thromboembolism, lung disease, even without RVH, COPD can have right axis because of the shift in where the heart is located in the precordium. Left posterior fascicular block. There, left anterofascicular block is left axis, left posterior fascicular block is right axis, and inferior wall MI is DD for left axis, lateral wall MI is DD for right axis. In some individuals, right axis can be normal. Arm electrode misplacement, which we are going to discuss later, a dextrocardia, left side pneumothorax. Indeterminate axis, both 1 and AVF are negative. Hyperkalemia and some VTs will have indeterminate axis. So ultimately, we should know how to decide the axis. And another way is, we know lead 1 is 0, we know the AVF is 90, we know lead 2 is 60 degrees. In a given lead, if QRS complex is highest in a particular lead, that is the axis of the net axis of the heart. If lead 2 is tallest, QRS complex is tallest in lead 2, axis is 60 degrees. If lead 3, tallest QRS is complex is in lead 3, axis is 120 degrees. If QRS is tallest in lead 1, axis is 0 degrees. That's how you should decide. That is parallel to the lead. And another concept is perpendicular. Equiphasic QRS complex, wherever we find, the axis will be perpendicular to it. But these two are easily, they are sufficient to diagnose. So we have seen, we have discussed about frontal plane axis. Let us see vertical axis, which is not horizontal axis, which is not usually discussed much. These are the 6 chest leads. In the second intercostal space, V1 to V6, that's how we locate different chest leads. And these are detecting the electrical activity of horizontal axis. Center point, Wilson's terminus. The central point of all the leads in the chest is known as Wilson's terminus. That is the point from where, like augmented leads, V1, V2, V3, V4, V5, the electrical activity is detected in this horizontal axis. So how to diagnose axis change in horizontal ways? If QRS R to S transition, V1, look right sided lead, septal depolarization small r, rest of the depolarization is away, so there is a S wave in V1. V6, it's a lateral lead, septal depolarization small q, predominant depolarization positive r. So V6 will have largest r, V1 will have largest S, because Depolarization starts from septum to the lateral. So ideally V4 is the V2 through V4 leads are the leads where R to S transition is expected. That is S should become R. If the transition is affected, there is a change in the axis of the horizontal heart. So if QRS starts positive in V1 to V2, that is very early, that is called early transition. The reasons are RVH, RBBB, so on and so forth. Those are the pathological conditions which are known to have early transition. If we see the subject, the pictorial picture mentioning clockwise rotation and counterclockwise rotation. The heart should be, the depiction is heart should be viewed from below. Right ventricle is not right side, left ventricle is not left side, right ventricle is anterior, left ventricle is posterior. So right ventricle is looking very close to the heart, left ventricle is posterior. If we see from below and if it rotates this side, that is counterclockwise rotation. So heart rotates towards the left side, it is counterclockwise rotation, will have early transition. If it is rotated opposite, it is a clockwise rotation, it will have late transition. Sorry, I have told reverse. So clockwise rotation will have late transition. We should understand as if we are looking at the heart like this. Right ventricle is anterior, left ventricle is posterior. If it is turning this side, late transition, clockwise rotation. If it is turned this side, counterclockwise rotation, which will result in early transition. How will you see? If R wave is already QRS gets started in V1 to V2, early transition. So these are the routine benign conditions which will have early transition. It looks abnormal. RVH, RBBB, posterior valami because of the R wave, which is equivalent to Q wave in anterior valami. WPW syndrome because of the delta wave. So this is clockwise rotation, which will be most often we see this poor precordial R wave progression. These many conditions will have this poor R wave progression because of the rotation, either because of the conduction abnormality, fascicular blocks, or because of the ventricular hypertrophy, ventricular LVH, and technical defects, high placement of the leads. So most importantly, where anesthetist assess for risk stratification prior to surgery, or a physician was asked to risk stratify the patient for surgery, or a cardiologist asked for, most of the times we will see poor R wave progression. Poor R wave progression is not always equal to, it's a differential diagnosis anterior MI. So it is not always anterior MI. There are so many conditions which can have the poor R wave progression. Still it is not anterior MI. They are physiological, not malignant condition. Let us see this ECG practically. There is V1 QS complex, V2 still QS, V3 expected to have R wave but still not at R wave. V4 predominant R wave should be there but still not there. V5 has R wave. So it's a poor R wave progression. The patient was sent for a risk stratification prior to surgery. Should we do angiogram or not? Is it equivalent to anterior MI? Poor R wave progression here it is probably due to LVH. Why? Why? Because any sudden transition is against anterior MI. Lack of T wave inversions is against ischemia. And normal size R wave in lead 1 also makes MI unlikely. So this is how, in a given poor R wave progression, in a Q anterior MI, if anterior wall MI is favored, if there are T wave inversions in V1 to V3, and R wave amplitude should be low, it should be less than 1 mm. And it's a small caveat is COPD can have that. Which are against ischemia in a given poor R wave progression, or sudden transition from S to R, sudden transition is against ischemia, and once we change the electrodes, the R wave progression is improved. That is because of high placement of electrodes. So poor R wave progression is not always ischemia. There are conditions which can have it. So next we shall observe P wave. Like we have observed the P wave. P wave is because of atrial depolarization. SA node cannot generate surface it cannot generate activity on a surface ECG. So it will depolarize atrium. Atrium will have P wave. Right atrium gets depolarized towards anterior. Upper right atrium depolarizes towards anterior chest wall. Left atrium and lower right atrium depolarizes towards posterior side. That is the reason why initial part of the P wave in anterior leads is positive because it is directed anteriorly. Later part of the P wave is because of the left atrium and lower right atrium, which is directed posteriorly. So it is a negative wave in anterior leads. An anteriorly placed lead will detect upper right atrial activity as a positive deflection, left atrial activity and lower right atrial activity is a negative deflection. A biphasic P wave in V1, which is an anterior looking lead, will have a biphasic P wave. Initial positive P wave is because of upper right atrium. Next, followed negative wave is because of left atrium and inferior right atrium. So biphasic P wave is normal in V1. That's how the pathology also gets changed. In a frontal pain, that is frontal lead, which is the best lead to diagnose P wave activity in frontal lead 2, because normal P wave axis is 60 degrees. The lead which have 60 degrees is in frontal plane is lead 2. So best activity is seen in lead 2 in frontal plane for P wave. So in frontal plane, that is the normal morphology of the P wave. In lower picture is showing right atrial enlargement, left atrial enlargement. In a lead 2, right atrial enlargement will give large amplitude. Left atrial enlargement will give prolonged duration of the P wave, because later part is left atrium, initial part is right atrium. So in lead 2, right atrium will affect amplitude, right atrial enlargement, left atrial enlargement will affect the time. So duration is increased. The same physiology, if we see lead V1 will see positive RA, that is positive part of the P wave, and followed by negative, because left atrium gets depolarized towards the posterior side. V1 is an anterior lead, it gives a negative deflection. So if there is a left atrial enlargement, L wave gets more amplitude and more time, that is more 1 mm more height and 1 mm more width will give left atrial enlargement. So that is the physiology behind different waveforms in lead 2 and V1. So this is just P mitral when left atrium is enlarged, P pulmonal when right atrium is enlarged. P pulmonal will have tall P wave, P mitral will have more duration. If we dissect the normal QRS complex, sinus node followed by atrial depolarization, followed by AV node, his bundle branch and Purkinje fiber, all are silent, they cannot generate any wave. Only atrial muscle can generate a wave, which is a P wave. So all those structures are silent. They become evident in the form of prolonged PR interval, isn't it? So AV node or his bundle disease or bundle branch generated, they will express in the form of prolonged PR interval, because they cannot generate a wave. So prolonged PR interval, it is not a AV node disease. It entire the conduction up to the infraction system, followed by QRS, followed by T wave. So normal PR interval is 120-200 millisecond. If it is short, pathology is WPW syndrome, axillary pathway which has bypassed the conduction system. If it is prolonged, first degree AV block. PR segment is not always isoelectric. It can be depressed up to 0.8 mm. Still it is normal, because PR segment deviation is because of atrial repolarization, which is evident in certain cases of MI when there is atrial infarction. So usually we say PR segment depression is pericarditis. No, PR segment depression still can be possible in MI. So next coming to the SA node, AV node and bundle branches, we should understand what is the reason for different waveforms and different bundle branches, so that we will understand VTs and localization of MI. If we see, electrical activity has spreaded from SA node, AV node, his bundle, then right bundle and left bundle at a time. In a given right bundle branch block in the first picture, where the horizontal mark was kept at the right bundle, there is no right ventricular depolarization through the right bundle. The bundle electrical current has to travel through the left bundle, then through myocardium, across the myocardium to the right ventricle, isn't it? Right bundle is blocked. If we see right-sided leads, V1, initial septal depolarization is because of the median fascicle of the left bundle. So that is intact. So V1 is looking at septal depolarization as a small R wave. Next, there is no right bundle to conduct electricity towards right ventricle. So the left bundle gets depolarized, which is observed as S wave in right-sided leads. And followed by, finally right ventricle gets depolarized through the left ventricle. That is the reason for another R wave. So R prime in right bundle branch block is because of three phases of depolarization, what we have discussed in three colors: septal depolarization, predominant ventricular depolarization and basal depolarization. Here there is no right bundle, septal small r, entire left ventricle big S, and finally right ventricle through the left ventricular myocardium. It is having another R. R prime in RBBB in V1 is because of this.
if we see lateral leads, the septal depolarization is intact, which is shown as small q in V5, V6 and 1 and AVL. And being a left oriented lead, entire left ventricular depolarization is positive deflection. Late right ventricular depolarization is S wave. So there is an S wave in V5, V6, 1 AVL in right bundle branch block. Okay, so in a ventricular tachycardia with a right bundle branch morphology, if we see V1, R because of right ventricular depolarization is tall. If we see which is opposite, initial R is tall and later R is small, it's not a typical right bundle branch block, it favors ventricular tachycardia. In a given tachycardia, if we understand what is normal RBBB, what is normal LBBB, if it is not followed, it is a pathology. In a RBBB fast ventricular tachycardia, there are left rabbit sign, right rabbit sign. The physiology is this. So RSR prime physiologically which is physiologically will depict like this. Coming to the left bundle branch block, left bundle got blocked. AV node will depolarize RV through right bundle. There is no septal depolarization. One AVL V5 V6 should show small Q waves which are laterally oriented leads. Here septal depolarization is absent. If we see Q waves in one AVL V5 V6 in a fast tachycardia, which is left bundle branch looking like morphology, it is not LBBB, it is a VT. The expected septal depolarization is not there. Expected depolarization should not be there in LBBB. If it is seen, it is VT, it is pathological. So we should understand what are normal waves. So V5, V6 lateral leads, no septal depolarization, no Qs, monophasic R. And because a left bundle is blocked, electric activity will travel from a right ventricle through the right ventricle. Entire will have lateral lead will have positive complex. So if you understand what is R, S, R, why there is in undergraduate they used to teach William, W in V1, M in V6 is left bundle branch block, Marrow, M in V1, W in V6 is right bundle branch block. But we should focus on what is the physiology behind this. Then only we can understand pathology, abnormalities. So I hope you understood. So this is left anterofascicular block, same thing. Left anterior got anterofascicular got blocked. Still septal depolarization is there because it is because of median fascicle. It will generate small q in 1 and AVL and vice versa small r in lead 3 and AVF. Because left anterofascicular block is blocked because of the conduction abnormality, there will be poor R wave progression. Left axis, poor R wave progression, small q in 1 and AVL, RS complexes in inferior leads, left anterofascicular block. Right axis deviation, small r and large s in 1 and AVL, small q and opposite is left posterior fascicular block. So axis change because of the anterofascicular and posterior fascicular block. As I have told you, left axis deviation, the differential diagnosis are one is positive, AVF is negative. In left anterofascicular block also same thing happens. So both are left axis. Most of the time we will get referral for echocardiogram looking at QS complexes in inferior leads. A patient is a known case of hypertensive. Actually it is small r, subtle r and it is left anterofascicular block. The same patient will have poor R wave progression. Poor R wave progression is equivalent to anterior wall MI. And there is left axis deviation with which is looking like inferior wall MI. So we will get a consultation for to see for LV function whether it is a old MI. Actually its LV function is normal, is LVH. So poor R wave progression is seen in LVH. Left anterofascicular block will cause it will mimic inferior wall MI. So that's how we should differentiate between the two. The same way left posterior fascicular block is a DD for lateral wall MI because lead 1 and AVL will have lateral wall MI changes. So that's how we should differentiate old MIs from fascicular blocks. And coming to the wide QRS, this is most important, most often we encounter in practice. Wide QRS complex, hyperkalemia, left bundle branch block and WPW syndrome. Even hyperkalemia can present as a left bundle branch block. If we see the QRS complex, hyperkalemia will affect entire thing. Being a metabolic abnormality, it affects all fascicles equally. So it will prolong both wide and initial and late terminal portion of the three phases of the depolarization. WPW will affect only, it is an axillary pathway, it bypasses the routine conduction system, it will affect only the initial portion. Left bundle branch block is because of the disease in the conduction fascicles, it will affect wide terminal portion. So if we see the QRS complex, if only the widened part is late, it is left bundle branch block, it is early, it is axillary pathway, both hyperkalemia. That's how we should differentiate wide QRS complex between these three things. So bifascicular block, the definition is block in two of the three conduction fascicles. Three are right bundle, left anterior fascicle and left posterior fascicle. It takes one of the following form. Left bundle, because both fascicles are involved, it is a bifascicular block. Right bundle plus LAFB, right bundle plus LPFB. Isolated right bundle branch block cannot cause axis change. If there is an axis change associated with right bundle branch block, there is a associated fascicular block. Left axis with right bundle branch block, LAFB. Right axis LPFB. So trifascicular block is along with that if there is an increased PR interval or alternating bundle branch block, one time left axis, one time left axis also will comes under trifascicular block. Coming to the next segment is Q wave, abnormal Q wave. Normal Q waves are seen in 1, AVL, V5, V6 or any anteriorly placed loads because of the rotations. If the septal depolarization is seen in, if it observes, it will observe as a negative Q wave. So abnormal Q wave is more than 1 mm duration, more than 1 mm in amplitude. So first complex is QRS complex. Q wave that is a part of QR or QRS complex is abnormal only if it is wide more than 1 mm in time and amplitude. Exception is it can be seen in lead 3 which gets disappear with the deep inspiration, that I will explain later. Coming to the QS complex. QS complex is not always pathological. It can be seen, it is abnormal in all leads except in lead 3, AVL, V1 and V2. So QRS only we should see for amplitudes. QS complexes can be normal in V1 and V2. If we see this very important clinical point, if we want to analyze the Q wave, here what is the transition? Transition lead is V1 is S, V1 is QS, V2 is still S, V3 is still S, V4 still S, V5 is R. Here the transition is V5. If we have to compare the Q wave with the transition, Q of any size when seen in the precordial leads before the transition zone as a part of QRS, not as a QS. In any complex before transition zone as a QRS, without looking for amplitude, Q is abnormal. It's not a part of QS. If before transition zone, if we make out any QRS, that is an abnormal Q wave. And almost 100% indicative of MI, highly specific point. So transition zone applied to presence of Q wave as a part of QRS complex, not as a QS complex. Because QS can be normal in V1 and V2. The same thing, most of the times QS is seen in V1 to V2, we'll get a consultation for old anterior MI to look for coronaries or echocardiogram. See V1 and V2 QS complex are there, V3 small R wave is there, V4 still small R wave, V5 R wave, V6 R wave, actually it's a poor R wave progression because transition zone is V5. QS in V1 to V2, 20% of the cases can be septal MI, anterior MI. QS that extends to V3, often anterior MI. There is a possibility of, high probability of anterior MI. If that QS extends to V4, it's definitely anterior MI. So, and the same thing, as I have told you, QRS complex having before transition zone is always abnormal. So, there is a Q wave in AVF lead 3, but still it is not abnormal because if we see the initial inspiration, it gets disappear. In expiration, it appear because of the horizontal orientation of the heart. Lead 3 and AVF can have Q wave, which will disappear with inspiration. The same thing, QS in 3 AVF may not be pathological always. If we see QS in lead 2 along with 3 and AVF, always pathological. Lead 2 is clinching point in the diagnosis of old inferior MI. 2 and AVF can be inferior MI. If 2, 3 AVF, 3 and AVF can be inferior MI, if it is seen in 2, always pathological. So Q in lead 2 is always pathological. So ST segment is another topic. So coming to I will conclude very fast. This is the 3 electrode system, RA, LA and left foot. This is which is seen in our monitors, and 5 lead system. Coming to the special leads, very important, right sided leads. To diagnose right ventricular pathology in acute coronary syndrome, we will utilize right sided leads, particularly V4R. Reversing the same leads toward the right side of the chest, or just reversing the V3 and V4 towards same intercostal space towards the right heart. What is the importance is, this is the algorithm from Hust textbook of cardiology, where localization of inferior wall MI can be because of right coronary artery occlusion or left circumflex occlusion. Based on V4R, this is the algorithm which is framed. So V4R lead, whenever inferior wall MI comes, is in the emergency, it's very good habit to see for V4R, because RV MI is preload sensitive. It will respond to fluids. Inferior wall MI, whenever patient is in shock or even not in shock, it's very good habit to see right-sided lead. If there is an inferior wall MI, associated RV wall MI, it will respond to fluids. And we should lock, and NTG. If we keep NTG in an inferior wall MI, patient will go into shock, because RV is preload sensitive. Already RV MI, preload we are decreasing because of the venodilatation, patient will go into shock. So to diagnose that RV MI in a given inferior wall MI, and to localize whether it is left circumflex artery or right coronary artery, V4R ST segment, if right-sided leads, V4R if you observe, ST is elevated in V4R, that is localizes to RVMI. RV branch can only come from RCA. If there is RVMI, RCA is localized. Second complex, distal RCA, ST is not elevated, but T wave is upright. So it is distal RCA. Third complex, V4R, there is a T wave inversion, it localizes to LCX. So what is the importance of V4R? Number one, it diagnoses RVMI. Number two, it localizes, differentiates between RCA and LCX. There is a MBBS teaching that if lead ST elevation lead 3 is more towards LCX or lead 2 is more RCA. But when I have studied this algorithm during my MD in Hust, it was given different. I have been following the same for the last 6-7 years. It's not so. Simply looking at lead 2, ST elevation 3 more or 2 more, as per this algorithm is not correct. If we see flowchart this side, we don't have V4R lead. If there is an ST elevation in lead 1, it is LCX, because 1 and AV are lateral leads. LCX will look at the lateral wall. If there is an elevation in lead 1, it is LCX. If there is a depression in lead 1, it is a reciprocal change, it is RCA. If lead 1 is isoelectric, then only you should go for next step, lead 2 more than lead 3. If lead 2 is more than lead 3, it is LCX. Still it is not RCA if not so. So lead 3 localizing RCA directly is not correlating with the anatomy. Then we have to see for ST depression ratio to ST elevation ratio, which is known as Kosugi criteria. I think these steps are sufficient. So this is from the textbook of Braunwald, where proximal RCA occlusion have ST elevation, distal RCA occlusion has only T wave upright, LCX occlusion has T wave inversion. So posterior leads, V7, V8, V9, there is no definitive intercostal spaces just below the tip of the capilla. V4, V7, V9, V8, V9. Any inferior wall MI, both recording both posterior leads and right side leads, a good habit. So you see here is a inferior ST elevation in lead 2, lead 3, AVF, predominantly lead AVF. There is a horizontal ST depression from V1 to V3, which is diagnostic of posterior wall. To confirm it, we have changed those V4, V5, V6 to V7, V8, V9, which is showing ST elevation. There are posterior leads, V7, V8, V9, which is showing ST elevation, which is not there in V4 to V6. This is how to diagnose posterior wall MI. Next is Lewis lead. This lead is helpful in diagnosing, detecting P wave activity. Especially the particular scientist Lewis has framed this. If you want to see the P wave activity, there is a fibrillation or flutter. This is a modified leads where right arm electrodes has to be detached, and the electrodes has to be kept on the manubrium. Right atrium on the manubrium sterni, costal margin left atrial lead, and left foot lead near the lower costal margin, and monitor the lead 1. This is the original scientific paper published by Lewis, depicting first lead 2, there is atrial flutter, and rest of the things are modified leads. That flutter waves are not seen in all the leads. Only few modified leads are able to detect the flutter waves, in contrast to the routine lead. So the lead 1 and lead 2 are Lewis leads, where the flutter waves are significantly seen, and 4 and 5 are not routine leads, which are not able to detect the flutter waves. So to have proper atrial observation, we can change the modified lead, Lewis lead. This is Fontaine lead, which will observe the right ventricular pathology like epsilon wave, ARVC, arrhythmogenic right ventricular dysplasia. Same thing, modified leads to detect right ventricle. This type of changing lead is focused to detect right ventricle, epsilon wave. This is Brugada lead is very important. There is whenever there is incomplete RBBV and patient had giddiness or syncope, lead has to be kept in the higher spaces to detect the Brugada syndrome. So finally, this is lead reversal diagnosis. This is the algorithm which was mentioned to diagnose lead reversals, which is very complex, KISS principle. And this is a flow chart to see what are the lead reversals, which is also very complex. So this is a very easy method, Jones method for diagnosing lead by reversals. To have this, it's very simple, and we have to diagnose through logic. I told previously that AVR is right atrium, AVL is left atrium, AVF is foot, whether it's right foot or left foot. Augmented leads can only switch to augmented leads. Standard leads can only switch to standard leads. Standard leads are 1, 2, 3. This is the Einthoven triangle. If we see the right foot is neutral lead, which is not easily seen. We won't, that's a black color lead we usually connect. Right arm to left atrium lead 1, right atrium to lower limb is lead 2, left atrium to lower limb is lead 3. Axis of lead 1 is 0, as that right sided diagram is depicted. So Jones method is identify AVR. How to identify AVR? AVR is always P wave negative, QRS negative. This is the normal AVR. P wave negative, QRS complex negative, T wave negative. This is normal AVR. So here there is a lead switch. There is a lead switch. AVR is not looking like AVR. Let us identify where is the AVR. If we see, AVL is the lead which is looking like AVR. AVL has negative P wave, QRS negative and negative T wave. So AVL is left arm lead, AVR is right arm lead. The right arm is switched to left arm. So right arm is switched to left arm. So the diagnosis here is left arm, right arm lead reversal. Where is the AVR? AVR is in foot, AVF. AVF is looking like AVR, negative P wave, negative QRS complex, negative T wave. AVR is positive. So AVF is left foot. Left foot is AVF. So AVF and right arm leads are exchanged. So AVF is left foot. Right atrium and left foot leads got exchanged. So here there is another AVR also. The lead 2 is AVR, looking like AVR. Lead P wave is negative, QRS is negative, and T wave is negative. But still, augmented lead cannot switch to standard lead. So those standard leads are looking like AVR. They are not AVR. To diagnose right atrial switch, we are looking at the AVR. AVR will switch to only augmented lead. So this is right atrium to right foot exchange. Here there is no switch. AVR is normal. AVR is normal, but still there is a switch in leads. How we have diagnosed there is a switch in leads is P wave is negative in lead 3. So there is a switch and it's looking like inferior volume, which is not. So there is a lead reversal. So we have to observe another standard point. P wave is positive in highest in lead 2. Here lead 1 is showing the largest P wave. Lead 2 is showing the small P wave. So there is a lead switch. That lead switch is, what is the remaining frontal lead switch? Lead 1 is LA minus RA. LA minus RA. Lead 2 is LVF foot minus RA. Lead 3 is foot minus LA. So LA minus RA is lead 1. LF minus LA is lead 3. So those two loads got switched. So it is diagnosed on the simple basic point that P wave should be tall in lead 2. So coming to the neutral lead difference. There is a right foot lead also. By technically sister has changed the neutral lead. Neutral lead is RF. RF and from the beginning I am telling both lower limbs are equal. RF is equal to LF. So technician has changed right foot lead to left foot. We cannot diagnose because ECG will be normal. So that is not a harmful to the patient. Next is right arm is exchanged to right foot. Right arm is exchanged to right foot. Now what is the right arm? Right arm now became left foot. Right foot. Both foot are equal. So normally lead 2 is formed by LF minus RA. Here RA became RF. Both foots are equal. So the lead 2 will become 0. We will see ECG as isoelectric lead 2. Isoelectric lead 2. So any isoelectric or 0 complex in limb leads, there is a lead switch between neutral lead. In a similar way, if left arm is changed to right foot, the lead will get changed is lead 3. And both right arm, left arm is reversed. Both right arm and left arm is reversed and kept on foot. So lead 1 is directed in that direction, right arm to right arm to left atrium. Lead 1 will become 0. So the clue is any lead, if we see 0 complexes, lead 2 lead reversal, lead 3 lead reversal, lead 1 lead reversal, but lead 1 has another DD, COPD. So neutral lead 2, there is a switch between right atrium and right foot. Neutral lead 3, left atrium to right foot. Lead 1, both arms are switched, and there is a differential diagnosis COPD. That is called lead 1 sign of emphysema. If we see very small complex in R wave in lead 1, that is called lead 1 sign of emphysema, that we should depend upon other leads. So finally, so P wave should be largest in lead 2. Lead 1, 2, 3 should be isoelectric. AVR should look like AVR. Then only that there is no lead reversal. If you see this patient, a patient has come with chest pain to the emergency room. Cardiologist has ordered serial ECGs because patient is having risk factors. After a few hours, ECG has changed because sister has changed. So here is looking like QS complexes with T wave inversions in inferior leads. Actually, it doesn't happen so. In ours, QS complexes won't come. What was happened is there is a lead reversal. You see the P wave in lead 2 and P wave in lead 1. Lead 1 P wave is larger than lead 2 P wave. So that's how this, technical faults will result in misdiagnosis. So this is another ECG which is showing dextrocardia, which will looks like lead 1 and right arm or left arm reversal. AVR is positive and AVL is looking like negative. It looks like right arm and left arm got reversed, but the point is R wave progression is preserved in lead reversal, which is affected in dextrocardia. Thank you. This is the basics of ECG interpretation.